Hey everyone, my name is Patrick Sui from Houston Methodist, and I'm here to present our work, DeepAphasia, transformer-based recognition of aphasia in acute stroke patients with contrastive segment-level labels. So as we all know, acute stroke is a problem. It is the second cause of death worldwide, and third leading cause of disability in the US, with around 800,000 cases per year. Meanwhile, it's also almost we could say it's fully cured, as in it is treatable and preventable with tools that are already available to us. The problem being these tools are not always available at the right time for the right patients. This makes the challenge of further improving stroke outcomes one about accurate and early detection of stroke and stroke-related symptoms in the acute setting. And that is exactly what our lab has been working on over the past few years. We developed DeepStroke, a framework for detecting stroke in the acute setting using only data available to us in that stage. Our existing work primarily detects stroke from facial movements and some elements of sound from talking head videos of patients recorded during stroke triage, as you can see on the picture in the top left. Meanwhile, we kind of overlooked this equally important aspect of stroke assessment, speech and language, which according to American Stroke Association's famous acronym FAST, speech is an equally important and key component to acute stroke assessment. Our existing work primarily focused on the letter F, and we haven't paid enough attention to the letter S. More concretely, speech evaluation is routinely a standard procedure in NIH stroke scales subscore 9 and 10. The QT-step picture, the QT-step description picture that you see on the left is leveraged to assess the severity of language symptoms like aphasia and atharsia as clinical features that are highly relevant to stroke. So this means that AI models that could accurately detect aphasia in the acute setting could fill this gap, this speech gap within our existing work. Just as a quick reminder, aphasia is a large-scale language disorder that affects the ability to make or understand speech and read or write. It affects around 30% of acute stroke patients, and detecting aphasia early could help locate what part of the brain is being affected by stroke. We've been working on this problem for around a year, mostly from an NLP perspective, where we've converted the problem into a text classification task with the transcripts of the voice recordings of patients. We trained bird-style language models to make this prediction, and we were able to significantly improve their performance through a storyline-centric approach that also performed knowledge distillation. The problem with this work is that it only relies on language and text without using the audio component of the patient voice recordings, which is problematic because at the end of the day, aphasia is still a speech condition, right? And our new interest in the audio side of patient speech coincides with the fact that there's no current audio-based aphasia detection methods that would actually work in the acute setting. Existing AI-based aphasia detection are mostly trained on extensive documentations of comprehensive aphasia assessments, like from data from Aphasia Bank, which would require a speech-language pathologist to be present to gather. This is not available in the acute setting. So we went back to the QT-step description task, which we know for a fact is available in most acute settings, and gathered a data set of minute-long voice recordings from 268 stroke patients from our hospital system. These patients are labeled for aphasia by a triage nurse using NIH-SS subscore item 9, and further validated by an NIH certified research nurse. So how do we classify these patient recordings? For those of you who might have some background in the audio and speech modality, there are mainly two schools of thought for audio classification. You could either work in a time domain, and your model would take in the waveform representation of audio, as you can see in the picture on the left, or you could take an intermediary step and convert this waveform into a spectrogram, as you see on the right. So here are some quick infographics on how these models work. In the first class of models, the waveform-based models, like wave to vec, for instance, you can see on the bottom left, that it takes in the raw waveform of the audio as the input. And Hubert is like a more evolved version of wave-to-vec, where it similarly takes in the audio as waveform and then process it with architecture that resemble language models like BERT. On the other hand, we have a different class of models as represented by self-supervised audio spectrogram transformer that take in the spectrogram representation of audio as an image and feeds it into a vision transformer, which effectively converts the audio task into an image classification problem. And the mainstream literature in audio and speech processing is that the first class of methods, the waveform-based methods, outperform the second class of methods for speech tasks. This is even admitted by the authors of this paper, SSAST, that frozen wave-to-vec and Hubert can already match or outperform fine-tuned SSAST for speech tasks. And this claim is supported by a wider range of research in speech that report better performance with the waveform-based models across a wide range of speech tasks. However, we find the opposite to be true for our data. Contrary to the conclusions of prior literature, our baseline results showed that the spectrogram-based SSAST significantly outperformed the two waveform-based methods, which are, as far as the AUC goes, similar to dummy baselines. Nonetheless, the performance is still generally poor on the patient level, which prompted us to segment these minute-long recordings into 10-second-long clips and then manually label them based on aphasia features. The clinical intuition being that aphasia isn't evenly or uniformly distributed in patient speech due to its high variability. Sometimes a patient could sound very like aphasia in one part of the clip, and in a different part of their audio recording could sound like a healthy patient instead. And to illustrate the extent of this inner patient difference, I'm going to show you a few clips from our data set and see whether you could tell which ones of these are from a aphasia patient and which one of these are from a non-aphasia patient.
But its substance is obvious. The kid is in the cookie jar. I think I said a plate.
Okay, remember this is a description of the cookie theft picture, right? And then number 2.
And it's going to run over the water, and it seems like it's a nice day outside.
Okay, so raise your hand if you think patient number 1 is an aphasia patient. Okay, right, a lot of you. Right, how many people think patient number 2 is an aphasia patient? Okay, right, less people, right? Turns out patient number 1 is aphasia, it's not aphasia patient, and patient number 2 is aphasia patient. And here, for instance, are some clips that resemble more what most of their audio sound like. This again is patient number 1.
Those drawings I used to test my reflexes. Lady washing dishes while her sink runs over onto the floor, and the kid.
Okay, and then patient number 2.
Jump to cut the cookie jar, and then mom is cooking or is killing the dish.
Okay, you got my point, right? So to capture this, fully capture this inner patient differences, we implemented what we call contrastive labeling, where most patients are assigned at least one contrastive label on the segment that disagrees with this patient level label. This allows us to push our models to pay special attention to potential outlier segments and put emphasis on the contrastive acoustic features within each patient instead of the differences between patients. And it's also important to emphasize that while this is not the gold standard, it's not the gold standard for our evaluation, it only serves as an intermediary step for our training. All of the results that we're going to report in this presentation will be evaluated based on the patient-level labels provided by and validated by clinical personnel. Here's a quick visualization for our workflow. We start with patient voice recordings, and then we segment them. And the segments are used to fine-tune the 3 aforementioned pre-trained audio models. And this segment-level learning allows us to fully utilize the granularity of our contrastive segment labels and also avoid overfitting on patient-specific features. As you might have seen from the earlier clips, there are a lot of confounding variables, like a certain person's voice signature or their demographics. And contrastive labeling acts as a form of supervision that allows us to guide our models to focus on the acoustic features that are more generalizable to aphasia rather than specific to individual patients. And these models give us probabilities for how likely a certain segment is aphasia. And we use a tunable algorithm to perform patient-level inference with these probabilities from each segment. It's also important to note that to perform patient-level inference, we don't need additional segment-level labels, meaning that if we're trying to perform inference on new data, we don't need to hand label all of them for each segment to run our model. As for the results, the SSST-based model again outperforms the two waveform-based models, though the gap here is actually a lot smaller than what we saw earlier when they're being trained on the patient-level audios. And more importantly, across all three models, the segment-centric pipeline significantly outperformed the baseline that we saw earlier. In conclusion, we find that the segment-level learning paradigm is a lot more efficient and accurate at identifying aphasia on the patient level than models trained on the patient level alone. Spectrogram models also do not necessarily underperform waveform-based models because it depends more on the data settings of downstream tasks. Instead of being a universal rule, it seems to be something that varies more by a task-to-task basis. This means that SSST could be presented as a compelling alternative for pathological speech detection tasks, where Wave2, VAC2, and Hubert currently enjoy some kind of dominance, partly due to the Whitehouse assumption that they're better for speech. And for our next steps, we're interested in further exploring how detecting aphasia early in the acute setting could be clinically useful. One area is communication, as existing studies have demonstrated that aphasia is a main communication barrier between physicians and patients. If a stroke team would know ahead that a certain incoming patient has aphasia, it would give them time to prepare and also adjust to a different set of communication protocols that are optimized for aphasia patients. Aphasia would also help us differentiate between stroke patients and stroke mimics, which would be something that would greatly increase the diagnostic accuracy of stroke in the ED setting. And last but not least, I'm also interested in the intersection with between my work and the medical humanities, because when the speech-language pathologist is not present, the most that clinical personnel could do to improve aphasia patient outcomes would be empathy, right? And I'm really interested in the extent to which NLP and large language models could help us deliver that at scale. Thank you for your time, and please feel free to reach out to me if you have questions, and if you're interested in collaboration, either at one of my two emails or the email of my PI, Kelvin Wang.
Okay, thank you, Eric. We have time for maybe one question, if anybody has one. Over here.
Nice presentation. I have a question. How do you record speech? In what setting? In the in a standardized setting, or speech without any disturbances, noise control situations?
Right, the current data set is recorded in the ER setting, and in the future, we're also interested in exploring more earlier stages of triage, like on ambulances, for instance.
So, but when you train AI models, I just want to ask generally whether it should be in a standardized setting or the natural settings.
Well, the standardized settings are kind of hard to get in the acute setting, right? We have to do with the data that we have, and that's part of the reason why this problem is so hard, because there aren't a lot of high quality data available, and that's one of the challenges that we are trying to work towards.
Thank you.
All right, thank you very much, Peichi.
Thank you.